A big warm welcome back to the show, Nikki. How are you doing today?
I'm fine. Thank you so much for having me back on to talk about more about hormones. Hooray, I love it.
I know. I'm so excited. I'm so excited. This episode has been a long time coming because we're going to talk all about HRT, a very highly debated topic. But before we dive into that, just in case our listeners, this is the first time they are hearing your voice and not knowing much background about you, can you tell our listeners a little bit about who you are and what you do?
Sure. So I'm a medical doctor and I'm working in London, UK. I work in terms of clinical work and research work. So clinical work, working with men and women, although I have to say probably I see more women than men, I must say. Anything and everything to do with hormones. So that sort of covers the whole range, whether you're in the younger age groups, periods gone missing or struggling from that point of view, or of course in the whole female hormone journey, maybe you're getting older now and want to discuss how to feel at your best. You can still keep going, by the way, when you get older. That's me. So that's my sort of clinical work day to day, and then research in a similar vein. I research all things to do with hormones at University College London. And I've just recently written a book called Hormones, Health and Human Potential, and that puts together a lot of the things I've learned over the last 30 years or whatever, working in hormones, working with people. It's got little hormone stories in it there for people to have a look at. And then so people know me. Who am I personally? I love doing exercise, sport. I used to be a competitive swimmer, tennis player, etc. But my main passion and love is dance, ballet specifically. And I'm going into the dance school later on because we're doing a study there, for example, to talk to the dancers. So that's always a good opportunity to go there. And when I was in Australia many years ago, I was also doing research, was doing a similar thing, research, which fortunately also included lots of research with dancers. So again, I know the dance schools when I was in Sydney and Melbourne, where I would go myself to speak to the dancers, but also to get in a sneaky class myself.
I mean, you have to take that opportunity. You'd be unwise not to. So you have a few things going on, but hormones are definitely your passion, which I'm excited to pick your brain on today. Specifically today, we're going to talk about HRT, which is hormone replacement therapy. Can you tell our audience, I guess, a summary of what HRT is?
So it's generally speaking, it's a combination. It's for women, and it's a combination of estrogen and progesterone. Those are the two main hormones produced by the ovaries. So it's a combination of those. And as the name suggests, it's replacement or topping up or whatever words you want to use, which will occur in different situations according to your age. So that's essentially what it is, a combination of those two hormones. The only exception being is, which we'll probably come on to later on, if you're in the older age group and considering HRT, if you've had a hysterectomy, i.e. you haven't got a uterus anymore, then you can just give the estrogen by itself, but that's sort of like an exception. Generally speaking, we're talking about a combination of estrogen and progesterone taken in different ways, different methods, etc., which we can go into, and for different reasons according to the age group.
Yeah. And I wanted to also ask you quickly, what are the differences between HRT, obviously, because you're talking about, I guess, estrogen and progesterone being topped up in the body. What's the difference between HRT and hormonal birth control?
Yeah, the clue's in the name. You're absolutely right that they both contain on the surface. You put them side by side, and if you read the packet for what's in both of them, you will see the word estrogen in some guys, and you will see the word progesterone in some guys. But the big difference is that the type of hormones, those hormones in the contraceptive pill, are synthetic. They're not, it won't say estrogen, by the way. It will say ethinyl estradiol, and it won't say progesterone. It will say norethisterone or something like that, a derivative of it, which is made synthetically in the lab. And the purpose there is they are, of course, derivatives of those hormones, but because they're derivatives, not like the real thing, if I can put it that way, in the contraceptive pill, they act to stop ovulation happening. So that's why they're contraception, by the way. Okay, so they switch it all off. And although these synthetic versions of these hormones in the contraceptive pill, they fool the controller of all the hormones, the conductor of the endocrine orchestra, the pituitary gland, which is located in the brain. Although they fool the pituitary to say, look, don't bother sending any messages to the ovaries. We don't need them, thanks. We've got this. So they fool the pituitary gland, but they do not fool, for example, the bone and other tissues which look to these hormones. It's just to point that out, that the contraceptive pill is a very, very effective contraception because it just stops ovulation, stops the ovarian production of hormones. So that's what that is. Whereas in contrast, HRT, again, there are different formulations and things, but in general terms, the hormones in HRT are more similar, or indeed sometimes identical, and body identical, as we say, to what you would be expecting to produce yourself. And so in that case, you're not looking to suppress ovulation, you're looking to top the hormones up, hence replacement, you see. And so therefore, it won't be contraception, which is an important point to clarify. And the other confusing thing, I think it is confusing, to be honest, that if you look at a blood test, if I don't know anything about the woman and she has a blood test, and you show me the blood test of someone who is on HRT and someone who is taking the contraceptive pill, the woman's blood test on the contraceptive pill, everything will be low because the test in the lab does not measure these synthetic hormones we're talking about that's in the contraceptive pill. So the blood test, everything is reading low, just like a woman with functional hypothalamic amenorrhea. Right? So that's, by the way, we'll come on to that, I'm sure, why not a good idea to reinforce that suppression of hormones with the pill. Whereas if you look at the blood test of a woman on HRT, especially if the hormones she's taking are body identical, same to hers, surprise, surprise, they will show up on the blood test and you'll see them. So that is that's the contrast. I think that hopefully that's clarified that point.
That's so helpful. And I think where the kind of conversation leads next is one that you have led us towards anyway, which is the use of, I guess, different forms of HRT in supporting women that have functional hypothalamic amenorrhea, because I think a lot of times women seek medical care, which is very necessary during because they're seeking, what their options are while their period is missing. And a lot of the time, a GP or sometimes even a specialist will go, oh, just take the contraceptive pill. And like you mentioned before, obviously suppressing ovulation in a state where ovulation already isn't happening, probably not the smartest idea. But in this population of pre-menopausal women who are in this functional hypothalamic amenorrhea state, why might HRT be helpful? And are there specific forms that a person would be more suited to taking versus other forms which are not as suitable?
Yeah, so just to absolutely reinforce that point, it's worth doing. If you've got FHA and anybody, even a doctor, as you say, says, oh, just take the pill, this will give you a period, or whatever the words might be, I'm afraid to say that that is not correct. And please seek advice from a different doctor. It's very clear in the Endocrine Society guidelines, and here in the UK, I've got our sort of monitoring body called NICE, National Institute of Clinical Excellence, to change the guidelines. So there's really no reason why this is still being proffered. I know why it's happening, because it makes everyone feel better. the doctor's done something, written a prescription, and you will get a withdrawal bleed. If you're taking it sequentially, the contraceptive pill, you will get a withdrawal bleed. So it kind of gives you a false sense of security and a psychological boost. It's like, hey, something's happening, but it's not really something happening that your body's doing. It's just because you put these extra external synthetic hormones on. So just to reinforce, please don't do that. But so what do you do? Well, the most important thing is, of course, work with either of us or somebody and try and get your own periods rebooted. So try and look objectively with guidance at what you're doing in terms of your nutrition, the timing of the nutrition, the exercise, etc. The main goal is to try and restore your own periods as quickly as you can. But we know that that's not always easy. We accept. And it can be a slow process, especially overcoming psychological, things and changing your behaviors. It's difficult. So if it's like, well, this isn't going to happen quickly, it's going to take probably more than 6 months, realistically, right? We have to be realistic. And your bones aren't looking so good. Either you've had 2 or more stress fractures, or you've had a bone scan, a DEXA scan, as we say, and that's showing actually it's looking lower than we would expect for your age, especially the lumbar spine, very sensitive to estrogen. Then in that situation, for bone protection, taking hormone replacement, i.e. HRT, is certainly an option. It's not a get out of jail card, as I say to people I work with, but at least it's a temporizing measure if we're really worried about the bone health. And so what HRT? Well, from what we just discussed, obviously, like the good stuff, as it were, the stuff that is identical to what your body would produce. So this would take the form of estradiol, the most active form of estrogen, taken through the skin, a gel or a patch. Personally, I find that the gel is more flexible in dose, but anyway, you take that every day, either via the patch or the gel, and then you add in, of course, we said you must take progesterone. Micronized progesterone is identical to what your body produces. So again, that's the best option. And in some ways, we are trying to replicate what the cycle would be. So you take the progesterone bit in blocks of 12 days to correspond to what the luteal phase of your cycle might be once we get it started again, we hope, okay? So 12 days every calendar month if you're not having any periods, for example. And just to remember, I say take it just 1 to 12 on the calendar month, that's near enough, so at least you're going to remember to do it. You might get a withdrawal bleed, it's true, after you come off the progesterone. So again, this is another source of confusion. It's like, well, the pill also will give me a withdrawal bleed, but it's for a different reason, you see what I mean? It's because it's responding, the endometrium is responding to hormones, but in this case, it's responding to the good hormones, as it were, the body identical ones. So that's HRT for a younger age group woman as a temporizing measure in FHA. Personally, I would say to the person, look, we're just going to do this for 6 months. And then hopefully by then we've sorted out behaviors and everything, and then we can come off, and hopefully that's giving your body breathing space, and your own cycle will restart. Obviously, we don't want women who can potentially ovulate to be stuck on HRT forever. You know what I mean? It's just a temporizing measure in that case.
Yeah, you already answered the next question that I was going to ask you anyway, which is often how long should individuals in that kind of premenopausal working on FHA state stay on it? So roughly 6 months under the care of an endocrinologist who's checking in on your progress and still working on those behavioral changes.
Absolutely. Really super important. Yeah.
Yeah. And reiterating that HRT does not suppress ovulation. So within that, is there a risk of falling pregnant during that recovery process, or is it?
Yeah, that's a very good point. Because it's not contraception. I mean, realistically, if you're in FHA and, your energy availability is really low, your T3 is really low, it's unlikely you're going to suddenly ovulate the next day. Nevertheless, I always say, this is, HRT, we'll do it for a short time, check in, see how you're doing, keep an eye on the T3 to see if the energy levels are coming up, etc. But I do say you're absolutely very important point. This is not contraception. And, the body works sometimes in slightly mysterious ways, and it might suddenly do an ovulation. So don't count on it as contraception if you're not aiming to get pregnant, and obviously use barrier methods in that case. Condoms probably is the easiest, just to be sure if that's not your objective, because otherwise that could be slightly disconcerting. So important to say that, yes.
Yeah. I mean, I've had clients who have had FHA and unknown to them caught their first ovulation and fallen pregnant without even a cycle. So
that's actually really good when that happens, isn't it? I had someone I was working with to coach and she did want to get pregnant, just to point that out. That was her objective, to get her cycles back. So we were working on it, and then it was like she was so disappointed. Oh, it hasn't, nothing's happening, and it's like, but everything from my point of view was looking pretty good. She was telling me everything. Like, have you done a pregnancy test? And she thought I was a bit crazy. So it can happen. Yeah. Or I had another person that had one period. It's like, and I said, I try and aim. I don't know about you, but Sarah, but I sort of say, let's aim for getting those 3 regular periods under the belt. Then it's like, okay, we can feel a little bit more confident on the right track. She got the first one, very excited. Oh no, the second one hasn't come. It's like, have you done a pregnancy test? So yes, it can spring back into action pretty quickly, which is good. But obviously you need to be aware if pregnancy isn't your aim. Just bear that in mind.
Yeah, definitely. Now, within this scenario, let's imagine a person's been on HRT for roughly 6 months. They have made significant lifestyle changes where you would expect to see their own hormones kind of kicking into gear when HRT stops. When, I guess, you decide to end HRT in this premenopausal FHA recovery kind of scenario, is it still a little bit of a waiting game as to whether a person's menstrual cycle will kick in relatively soon, or is there like a period or a window of time you can kind of look at to see whether what you're doing now is sufficient or whether more changes are necessary to ensure that your periods return?
I think, what I do, I don't know about you, but generally, going through revising, if the periods, say the person has been on HRT for a bit, comes off and is disappointed and she's not pregnant and the periods haven't returned. So then what? Then let's sit down, let's go through the detail of what's going on, revisit, because what we might have sort of decided originally, when you come and sit down and look at it, it's like, oh, hold on, but you forgot that bit or something, whatever it is, or the person says, well, I was feeling so much better. Actually, I did start doing some running or something. So something might have crept in, which wasn't, whatever. So that's not a problem. So long as we discuss openly what it is, it's like, then we've got a reason. So we revise that. And also from the blood test point of view, it's really helpful to look at the T3, one of the thyroid hormones, which generally will be low if you're not fueling enough. So we'll see is that more in the middle of the range, looking a little bit better. And sometimes it's useful just getting an idea of what the FSH and LH in particular is doing. Sometimes it's, if you've got FHA, typically the LH is scudding around sort of 1 or 2. It's milliunits per litre, I believe the units for that. Anyway, but if we repeat the blood test and it's actually looking like 3 or 4, it's like, okay, it is a little bit more patience and whatever like that. So that's reassuring. And sometimes there can be this sort of intermediate situation where the person has put in place all the changes, everything's going swimmingly. And it's like, it is a little bit puzzling, frankly. The T3 is okay. It's like, oh, I wonder why the periods haven't started. And you do a blood test. And then you see that actually, if you didn't know anything about the person and you just saw the blood test, you might say, oh, that looks like PCOS. Because in the rebooting of your cycles, you can understand. The body is like learning to ride the bike again or whatever. It's like a little bit clunky at first. And so there can be a little bit of mistiming. So actually, you might see the LH is pretty decent level. You might actually see the testosterone up a little bit. And sometimes if people have an ultrasound at that point, there will be lots of follicles trying to do it. And this, I'm just warning people of this. because sometimes this has happened, and then the person has been told, oh, you've got PCOS, restrict your carbohydrate. It's like, oh no, we just spent the last 6 months trying to increase the carbohydrate availability, because female hormones love carbohydrates, by the way. So just be wary of that. The interpretation of the blood test in this scenario, the person that's trying to restore their periods, actually this little bit of the sort of desynchronization of the hormones, that's a good sign that things are coming. I mean, I have to be honest, sometimes even I have to hold my nerve. And there was one particular dancer I'm thinking of where, you know, it was like, oh, this is going on for quite a long time. But I knew, I was confident. We knew her story. And I said to her, look, I agree. It's just like being honest and open. I agree. This is a little bit high and going on for a bit longer than we thought, but I'm pretty confident. We've done everything. We've discussed everything. I don't think we're missing a trick. It will come good. And guess what? Just that almost the reassurance, the psychological aspect of FHA, by the way, psychological reassurance. It's like, no, hang in there. You're doing good. We'll get there. And lo and behold, period started pretty soon after that. So I think that's the other thing to emphasize, isn't it? The psychological component. If you feel in control and you know, you've got a good partnership and right, this is the plan, this is what the blood tests mean, explain, then you already feel so much better anyway. And that has a big effect on how your female hormones work.
So much so. And I love that you pointed that out. I think that misdiagnosis of PCOS is so common. And we often see that kind of, sometimes that presence of what looks like quote unquote PCOS after or during those first 12 months of recovery.
Yep.
But your body is learning this again. It's almost like a second puberty where it has to be able to fall back into a pattern. It's also why PCOS shouldn't be diagnosed when you're a teenager, because the body is still really learning how to do this whole cycle thing. It takes a little bit of time to get consistent.
Yeah, very important point. Second puberty, I like it. Exactly.
Yeah. So I love that you kind of you do what I do. I have a little bit of a checklist. Like, let's just go back and like look at all these different points and make sure we're hitting the nail on the head with a lot of these, because that's when people are like, oh, actually, no, this has changed or that's changed, or I've been a little bit inconsistent with X, Y, or Z. And then we can kind of go like, okay, that's fine. You're human. These things happen, quite. But let's get back on track to make sure that the body feels supported enough to make sure that the cycles return. So I feel like that's a pretty good overview of HRT for FHA. Now I kind of want to jump onto HRT, I guess, for its classic use in postmenopausal women. But before I do that, there's one other question that I have, I guess, which is for women of that typical, I guess, premenopausal age. There are other conditions where periods might cease. The one I'm thinking that comes to mind most rapidly is primary ovarian insufficiency.
Yeah, that's a very good point. So FHA, it's a diagnosis of exclusion, as we say, in the trade, as it were. So before we absolutely say that, I mean, already once you've spoken to the woman, you know, gone through the history, it might sort of seem pretty obvious. Well, yes, she's not eating carbohydrates, she's doing fasted training, she's concerned about her weight. It might all seem, that's sort of straightforward, FHA, but you must always back that up and have excluded other things. For example, POI, so primary ovarian insufficiency. So that is when effectively you have a very early menopause, when actually it's not the master control of the pituitary gland, the conductor of the endocrine orchestra. It's not there that has dialed everything down. It's actually the ovaries themselves have decided to retire a little bit early, right? Early retirement, okay? So, but you will see that on the blood tests. So you see that we mentioned the hormones FSH, LH, you know, the ovarian hormones, estradiol, progesterone, and the thyroid function test. So I have a little sort of run of blood tests. I just like, for everybody, we just do that, boom, get that out of the way, those ones I've just described. And that is how you the WHO, World Health Organization definition, classification of why a woman's periods have stopped. By the way, first thing, obviously, check, not pregnant. I know it sounds obvious to say, but we should say that. Assuming the woman isn't pregnant, her periods have stopped, that is like, oh, and she's, you know, in her 20s, 30s, whatever, it's like, so then take the history, then do the blood test, the ones I've mentioned, just tick off that the LH is low and the prolactin is normal. Now we're on the track probably of FHA. If the FSH and LH are high, as you would see in menopause later on, but actually it's happening in a younger person, like high, I mean, by the way, you know, it's like, this is out of the range, really high, then yeah, that is a difficult conversation, but always important to be honest and open about it. And that looks like the ovaries maybe aren't playing ball, or it could be a true PCOS woman. Okay, so actually her estrogen will be fine, but her testosterone will be really high, and the history is not suggestive of FHA. So that's a very important point to clarify, because it's really important, because it will be totally different. The woman with FHA or POI, actually in those cases, those sorts of women, then that's where HRT will be helpful, you see, especially the POI, of course, that will be you know, not just a temporary thing, and it will actually be goes in there with a decent dose of HRT, whereas someone with PCOS, like we said, that's a totally different situation. Actually, there's nothing wrong with the axis, it's just it's got a bit out of sync, and so that will need a different approach. So yeah, thanks for mentioning that, really important to highlight that.
Happy to. Now moving into, I guess, the traditional age group where menopause naturally happens and our body starts producing as much estrogen and progesterone on its own. We spoke last time about the importance of hormones in general, not just for reproduction, but how they have impacts widespread across the body. And those can be really important for our mental health and our physical health and our cardiovascular health and so many more things. I think classically there's a really big hesitation to take HRT, mostly because we hear of like horror stories from maybe our parents or our mothers who had taken HRT in a different form when they started menopause and not having a great experience. What are some of the, I guess, pros and cons of taking HRT, and how is HRT different in the forms that we have now compared to the forms that I guess a lot of people hear about, those horror stories from before?
Yeah, well, what really was a problem for women was there was a big study which came out of America. It is several years ago now, but what happened was they had done a study about women taking HRT in the menopausal state, and what happened was that the media got hold of the study before it had been properly reviewed and published, blah, blah, blah. And of course, we understand media, it sells a headline, you know, a shock horror headline, oh, HRT causes breast cancer, and understandably, the usage of HRT plummeted. But when everyone had calmed down and everyone had, the doctors and scientists looked over the data, it was obvious why it did seem that quite a lot of women were getting breast cancer on HRT, because the study in America, and with all due respect, lots of the women were overweight, which is the main risk factor for getting breast cancer, okay? BMI quite high. And also they'd started taking HRT a long time after menopause, in their 60s, when their menopause is typically like 50 or something. So there were sort of flaws in the study from that point of view. And it was a long time ago, and you're quite rightly, it's kind of old-fashioned HRT. So what's the situation now? Well, the situation now is there is a slight increase in the risk of getting breast cancer if you take HRT. In women ages 50 to 59, there's an extra 4 cases per 1,000 women. This is exactly the same risk as taking the oral contraceptive pill. I repeat, it's the same as taking the oral contraceptive pill, and no one talks about that, do they? And it contrasts, like I said, if you are leading a slightly unhealthy lifestyle, you're overweight, you're not taking exercise, you're drinking a lot of alcohol, you're smoking, all those things, then that whopping increase of 24 cases per 1,000 women. Whereas if you're a woman who's taking 2.5 hours of exercise or more per week, then it decreases the number of cases of breast cancer by 7. So if you do your maths, the most important thing and message for women going through perimenopause, menopause is, number one, it's a good opportunity to revise what you're doing in terms of lifestyle. So if you know, exercise, strength exercise, are you doing your exercises, you know, whatever that might take, ballet, I don't know, whatever it is, and just have a look at your nutrition. How's it going? Are you eating in a consistent way, not too little, not too much, sort of thing, and lots of protein? If you sort of ticked off those things, then you can actually, you know, there's no harm, in my opinion, trying HRT, because at least then you'll see the main indication for taking HRT is quality of life. And like you said already, Sarah, that, you know, as these female hormones dwindle, there's going to be, you know, negative effects potentially on mental health, mood swings, etc., and also physical health. You know, hot flushes, poor sleep, which poor sleep makes everything seem worse, doesn't it? You know, bone health, actually, that is now a new primary indication for HRT. There's also the increased risk in cardiovascular health disease as we get older in menopause. So, you know, there are certainly benefits from HRT. And fortunately, the only women for whom it is contraindicated is if you are a woman and you've had, unfortunately, breast cancer, which is estrogen positive. Then obviously, clearly, and you're taking medication to lower the estrogen, then obviously it's not going to work for you. But there are other non-hormonal things. So that's generally when I see women coming to me in perimenopause, so the periods are becoming irregular, erratic, or they've just recently reached menopause and not feeling so good. Yes, we do a quick, it's like the FHA in that sense. Let's go through what you're doing in terms of your nutrition, your exercise. Let's really nail that and make sure that's as good as that can be. And then let's have this discussion about HRT. And let's try you on the best form and a low dose. In England, we have had a bit of a problem. There has been a certain celebrity menopause doctor who has been doling out very high doses of HRT as immediately. So it might be some women, well, we need higher doses than the others. Obviously, we're all different, but general rule of sort of medicine, start off at the lowest possible dose and then we try to titrate up. And the forms, like you said, very important to emphasize, much improved to the old-fashioned horse urine and all this stuff. Now, the best way of taking the estrogen is through the skin, so you don't have to take a tablet, patch or gel. I've already mentioned, I think the gel is even more flexible and discreet, frankly. And there's little sachets of them. You can get in the pump, but actually little sachets, so you don't have to hike a whole pump through customs. It's just like, oh, you know, what do you call it? No, not the, you know, the fluid control thing. It's like, yeah. So yeah, that one. It's like, no. Anyway, so the gel is really flexible, comes in really small sizes, and then you can sort of mix and match and see how you go after 3 months, and we might increase that. And then the progesterone, we've already mentioned, micronized progesterone, typically in a soft capsule. In the UK, the brand name is Utrogestan. I think it's also available, I believe, in Australia, or Prometrium is the other brand name of that thing. And then you have a choice. In the younger woman, we mentioned you take that progesterone in blocks, right, to sort of mimic a cycle, as it were. But in the perimenopause, well, if you're still having some sort of periods, then actually you might as well try and sync it with what your own body's already trying to do. But if your periods have stopped entirely, you have an option. You can sort of reproduce in a sort of a crude way the menstrual cycle and take it in blocks, or you can take the progesterone continuously every day. Me personally, I just kind of thought, well, I'm going to take it in the blocks because it kind of seemed logical to me. But my friend who reached menopause at the same time, she said, oh, no, I've had enough of all that bleeding lark. I just want to go on the continuous one because typically you don't bleed. So it's entirely your choice. And then if anyway, 5 years after menopause, all women, we advise them, and I have just recently converted to taking the progesterone every evening. The reason we take the progesterone every evening, by the way, is because it has a slightly soporific effect, which is great, a natural sleeping aid. And so you take it last thing at night. And what we're looking for is for you basically to feel better. So the quality of life, so you can get on with your job, get on with what you're doing, just enjoy life a bit more. And but the other thing to say is, if we start off at a low dose, then I say to women, let's leave it 3 months and see how you're doing on this. Come back, let me know. If you're still noticing problems like low mood, feeling, hot flushes, whatever it is, if that's still not quite right, then we can gradually increase the dose, and just go like that. And your requirement might change as you get further away from the menopause, is what I found, because the ovaries, although they have retired, sometimes they were maybe think about a little bit, and but definitely you might need to increase the dose anyway as you get further and further away from the menopause. But it's a very individual thing. So if you haven't got a contraindication for taking HRT and you're not sure, then actually, as I say, that I think, and the risk benefits, then actually that you've got kind of nothing to lose by at least giving it a go, and you've sorted out your lifestyle. So that's my approach to HRT.
Yeah. And I think just to kind of refresh in people's minds, like as we go through menopause, the main risk factors are obviously cardiovascular health. We know that women postmenopausally have such a higher risk of cardiovascular disease and heart attacks and things like that, because estrogen is cardioprotective. And when we don't have that, and maybe when we're not feeling our best and not engaging in as much movement as we did when we were younger,
good point,
our risk really increases, as well as bone health being another really, really big one to
that's a really big one, the bone one. And recently, certainly in the UK, HRT, the main thing is for quality of life, so you feel better. But actually, we now know that it's actually can be almost a primary treatment for bone health. And certainly, because I had FHA in the past, my bones weren't so good. Even back then, people were saying to me, "Oh, you should think about HRT." And I've got a family history of osteoporosis. So listen, it's not, we have to do everything we can ourselves as well. It's not like a get out of jail card, like I said, for the women with FHA taking HRT, but at least it gives you a fighting chance, and you feel proactive, and you're backing that up with everything you can do. So it's the combination which is really important to consider.
Yeah. I mean, there are like no magic pills exist. But
no, I'm afraid it's not the elixir of youth, just to clarify that again. But and it's not, now you're going to be 21 again. But at least it will hopefully help you to continue to get the most out of your life. And as we're living longer, especially women, you can be spending a third of your life post-menopause. So actually, that's a big old chunk of your life. You want to be at your best, don't you? And getting what you can out of your life, even in, I want to keep doing my ballet classes, for example.
Exactly.
So you have to think, what do you want to achieve and what's right for you?
Yeah. And my last question is, in that postmenopausal group, is it safe to continue with HRT, and how long are we taking it for?
Well, that's a really good question. And again, things have changed a lot. It used to be they would say, "Oh, you take it for 5 years and then you stop." Seemed a bit crazy, because it's like you feeling better, and now you take away the thing that's making you feel better. So now the most recent advice from the British Menopause Society, and no doubt the same in Australia and throughout the world, is that there is no arbitrary limit on how long you take it for. Personally, I've got this image of them prizing it out of my hand when I'm really old, right? So, but I think it will sort of become obvious for you as a woman. If you're feeling good on it and you've got no problems and everything like this, and certainly in the UK, we have 5-yearly mammogram screening is on offer. So, and it's making a difference and you feel good, then actually there's no reason why you would stop, is there? But on the other hand, if either you get, I don't know, you might get fed up of taking it or whatever it is, because my mother was taking it actually, but then actually as she got older, there were other things going on, and it became a bit fiddly, and she had to have other medications for other things. So, there might come a point anyway when it's like, actually, no, you kind of make your own personal decision when that is. So, really important to highlight that. So in contrast to the younger women, where I would advise, let's just use a temporary measure. Unless you've got POI, of course, then you're going to be taking it continuously. But the same for, menopause, use of HRT. It's very individual, personal choice. We must titrate the dose according to the individual, what they need. And also, again, personalization. When do you want to stop this? Or do you want to keep taking it like me, or whatever? So then that's really good to know that there is no arbitrary limit. But again, not all doctors are totally up to speed. Obviously, hormones are my passion. This is what I know everything that's been changing, and made some of the changes myself. And I'm a member of the British Menopause Society, done their training course, whatever. So, again, make sure you're getting, someone with the really most up-to-date advice and information.
Yeah. Yeah. And I love that you reiterated that it's important to start slow and start with a small dose, because also different people are sensitive to medications in different ways. And
exactly.
similar to when we advise people who are looking to support their mental health with antidepressants, it's very much like a case-by-case basis, and it takes time to figure out what's going to work best for your body. So patience is also really important, as well as working with someone that's really qualified and up to date and knows the best kind of situation for you and your body and your lifestyle. So always, anyone listening to this podcast, make sure that you're working with someone that's not just qualified, but is specialized in the areas that you need support in when you are going to see that individual. This has been eye-opening, and hopefully my goal with this podcast was to kind of remove a lot of, I guess, the overwhelm and the barriers that people might have in taking HRT, either as a support for themselves during that FHA recovery, or in that perimenopausal kind of state, to make sure that they can still support themselves lifestyle wise, but make sure they're physiologically giving their body what it needs to thrive and be optimal and function and feel good.
Yeah, well, quite. That's the most important thing. That's why my title of my book is Human Potential. Whatever your personal potential is, you definitely want to reach that, don't you?
And yeah, most definitely. And I guess my last question is there anything else that you want to add about the discussion around HRT that we haven't already talked about today?
I think one thing, sometimes it's like when you start it in the perimenopause, menopause, right? It used to be, again, things have changed, because the strict definition of menopause is a point in time when your periods stop, and it's retrospective. You look back and say, oh, well, I haven't had a period for 12 years and I'm in that age group of 45 to 55, right? But now, and that used to be like, okay, then you start HRT. But that seems crazy, doesn't it? Imagine you've got to suffer a year of not feeling great and then take HRT, like, oh, now you qualify. So actually, again, the thing has changed, which I'm really pleased to see. And that now actually, starting it sooner than later. If you're in the perimenopause, i.e. you've got really erratic cycles, typically shortening cycle length, and again, just not feeling great and getting some of those symptoms that the ovaries are retiring, then easing into HRT at that point to sync it almost with your cycles, what's going on, that actually is also now the new, a better approach. And I've seen it personally really work well. And again, this is very fine tuning, and certainly if you're having some periods already still, then it would be definitely a low dose of estrogen, because obviously your ovaries are doing something, and it would be the sort of the same dose of progesterone, because probably what happens first is the ovulation sort of doesn't work so well, and actually probably it's the progesterone that goes lower first. Probably, we don't know exactly, but again, it's all about the fine tuning and starting as low as you can and just seeing how trying to sort of get it right for the individual. So that's my only other thing. When to, we said when, how long for, when do you stop it, but also when do you start it?
Yeah, don't suffer in silence.
No, absolutely. Better to get it, and as you say, personal for you, better to try and get in sync with what works for you. And then you've got a good idea of okay, this dose and this way of taking it works best for me.
Yeah, 100%. And since we spoke last time, your Instagram has changed. So what is your new Instagram handle should individuals want to connect with you?
Well, actually, yeah, that was a whole debacle, but we won't go into that now. Anyway, but it actually gave me the opportunity to just make it all the same across everything.
Yes.
So Insta, Twitter, and Facebook. So just simple, straightforward, my name. So Dr. Nicky, Nicky, K-K-E-A-Y, Dr. Nicky K, there you go. And I try and post interesting things and podcasts and stuff like that. And then if people, prefer to look at a book, or there is I think there's a Kindle version, but also if you want a paper copy, then please, some of the stuff we've discussed here, we go into that with little stories to illustrate, like I said. So yeah, please have a look at the book. And my website has got further information about the book and advisory appointments, etc. So again, straightforward. Nicky K Fitness for the website, and Dr. Nicky K at all the social media things.
Amazing. And I will put all of those links in the show notes so that all of our audience can connect with you and get your brilliant book and pick your mind in an appointment should they need some further support. So thank you so much for taking the time today to discuss all things HRT. And to everyone listening, I hope you got a lot out of the episode. If you did, make sure to take a screenshot of wherever you're listening. You can tag myself at Sarah Liz King, or you can tag Nicky at Dr. Nicky K, and we will reshare those on our social media. But until next time, look after yourself, and I will be back with a fresh new episode you can wrap your ears around next week.
Brilliant.